I'm Dr. Lowthian. I'm doing a presentation today on some work that I did a little while ago now with kind of colleagues in Sale, but also across different universities. So in University of Bergen, Cardiff, and Virginia Tech. So quite a kind of international based team. And it's really nice to see that a lot of the team now progressed on to either being professors or two of the team are now doctors. So Madeline and also Kim Sukin, who uses Caroline generally as her name. If anyone's interested in the paper throughout, I recommend scanning the QR code if you want to read through it as I talk through. It is actually incredibly detailed, and I've tried to kind of use a lower level kind of language as I work through, just because I think as much as we all love the detail, it can get, I think the message gets lost otherwise. So I'm going to do my best to try and keep it simple, as much as I'm sure we all love technical detail anyway. But yeah, this is a paper looking at maternal mental health and children's problem behaviours, and it's a bi-directional relationship. So kind of thinking about the theoretical reasons of why children develop problem behaviours and how that's influenced both by the mother, but also kind of how they interact with their environment and how that then kind of impacts the mother later on as well. So thinking about kind of integrating theory to develop our models going through. Okay. So just to kind of give a background, I think kind of the other two speakers have done a really good job at kind of sharing this as well. But obviously at the moment, over 1 in 4 suffer from a mental health condition since COVID-19. And our study doesn't look at COVID-19 years, but I think it's important to think about kind of how times have changed, particularly with the cost of living crisis as well. Thinking about, if things were particularly challenging pre-COVID and pre-cost of living crisis, what does that look like now, and why are these results potentially even more meaningful than kind of what they were pre-COVID, pre-cost of living? So just to kind of also give some updated kind of results, looking at the National Survey of Wales, which to my knowledge is a representative generalisable study of adults in Wales, we can see that kind of well-being or mental health scores have declined over the last few years. So going from kind of an average score of 50.9 to 2016, all the way down to 48.2. And obviously these are marked decreases that we can see in people's mental health. What we're specifically interested in is in maternal mental health, and we know that it's one of the most important kind of earliest influences on child development. And there are numerous studies that show a negative association between maternal mental health problems and child development. I'm not going to kind of harp too much on about this because I think this is really well known and it's been really, really well researched. But I think what fewer studies have considered to do is think about the reverse relationship. So I think the idea is that children shouldn't be viewed as passive recipients of kind of parental behaviours, and they can be reactive and it can be cyclic and potentially bi-directional. And the theorists of kind of Belsky, Samaroff all talk about transactional theory, the idea that children both kind of take in the impact of their environments, whether that's parents, teachers, socioeconomic conditions, cultural aspects, intergenerational trauma, all of those aspects, they take in that, but they also react with that. And a lot of the kind of reaction or the kind of interaction with their environment isn't always captured as well. And that's kind of what our study aimed to do with linked data. So talk a lot about transactional theory in the paper, suggesting that there's a two-way exchange between behaviours. And labelling is a really nice example of this, which I think is kind of quite easily discussed. The idea that if a parent decides that their child has got challenging behaviours and they see them as a challenging child, that there's a chance that that child will internalise that label and then perform those behaviours continually in a really basic sense. There are also lots of literature which discuss how children sometimes challenge those labels and develop kind of typically despite that. So there's all sorts of aspects going on, and that's one of the reasons why we wanted to look at this. To give you a kind of overview of the literature currently, the way the literature used to manifest was through what we call cross-legged panel models. And because they didn't really adjust for a random intercept or kind of any covariates, this meant that a lot of the associations were quite biased, and there were numerous papers actually talking about how these kind of models, we can't really generalize too much from them, and they're only suggestive of bi-directional relationships, but we need to do more. So kind of the methodological advancement stepped up, and we started adding in random intercepts, and we can also add in covariates to think about how do we adjust for those confounding factors. when we're looking at bi-directional relationships. And some papers have examined that. So Zera has examined bi-directional associations, particularly between internalizing and externalizing symptoms for children. So for those who aren't completely aware of this kind of language, internalizing symptoms are things like mood disorders, so anxiety or depression in a really basic sense, and externalizing things are kind of like antisocial behaviors or aggressive behaviors. So I will try and use kind of that language, but I do sometimes slip into internalizing and externalizing, and I'm sorry about that, because I know that's a very psychological language, and that's not always kind of the audience I'm kind of delivering at today. But yeah, they were really interested in not only looking at sort of anxiety and depression and aggressive behaviors, but they were really interested in, does it matter who reports the behaviors and how that matters for associations? So for example, where the mother reported their own behaviors, for example, mental health problems, and their children's behaviors, there was an association. But where they looked at paternal reports of the kind of mother's behavior and then maternal reports of the child, there was less of an association. So their study essentially found that who reports what really matters for how the associations manifest. And obviously, if a mother has her own mental health problem, the way she will potentially report a child's mental health problem could be elevated due to their own kind of mood disorder. So lots of things to think about there, I think. And another study by Speyer also looked at something similar, but they looked at maternal distress and internalizing symptoms, so anxiety and depression, and then paternal distress. And what was really interesting is they found paternal distress had a relationship with both boys and girls' mood problems, but whereas paternal distress was more related to increased problems with boys, but decreased for girls. So there's all sorts of gender issues going on. And one of the things we specifically found out in this study was that there wasn't that much work done on socioeconomic status as well. So our study planned to kind of fill these gaps by thinking about how can we link cohort data with kind of administrative data to kind of come over some of those hurdles of self-report problems, but also integrate socioeconomic status, which would be really helpful for us to understand kind of how that manifests and adjusting for that in the model, which is really important when we think about mental health for both children and then parents. And we specifically only look at mothers in this study. That's mainly our goal, really. That's what we were interested in. That's one of the work packages that were outlined, and there's definitely room to do more stuff on fathers and kind of sort of three bi-directional models, but we just did 2 at the time. And when this study was done, it was kind of a cutting edge new methodology that hadn't really been trialed apart from some code that was in a paper. So that's kind of where we were at the time, and I'd be really keen to do some more of this stuff, but yeah, there's also loads of other things we could do. But yeah, just to give you an idea, we linked Millennium Cohort Study to Welsh GP data, and you can see in the kind of cohort concept diagram how that manifests. So we started off with 1,961 households in Sale, and then we got rid of a few more. We ended up with kind of 1,911 households overall that had singleton births. We removed twins purely because they were complicated to work with in this sense. I don't have an excuse for that, purely just because of complications and to make things streamlined and easier. And you can see that over time, the kind of cohort data, so the 1,714 increases up to time point 3 and then starts to decrease. And that's because the consent for data linkage was taken at time point 3 in Millennium Cohort Study. And that means that that's why we have more households that are linked there. And you can also see that the amount of households that are linked with GP data underneath that cohort kind of varying as well. And we can see that increase up to time point 3 and then that decrease. So we did have we obviously had attrition in the study, that was clear, and there are various parts of adjusting for that, and I'll talk about that in a moment. That's kind of how, if anyone's interested in how it all links up, this is published, but also I think the Tinjay et al. 2019 paper covers this a lot better than me, because they were kind of the pioneers of bringing this data in. Okay. The way we kind of worked this out, and as you can imagine, it's not always easy to link up cohort data with linked data or GP data. So what we had to do is think about how is the survey organized and how could we link the data linkage to the survey to make it harmonized, essentially. And this meant that, we knew that Millennium Cohort Study was collected at 9 months, 3 years, 5 years, 7 years, 11 years, and 14 years. And we thought, okay, well, how can we use the administered data to kind of link back to that? So we knew that the parent, and this could be mum or dad, or whoever else was in the household that was the main respondent, usually mum or dad, but could be someone else. We had to basically think, let's say, not structural strengths and difficulties questionnaire, that's the measure of our problem behaviours, were taken at 3 years. We then had to work backwards and say, were there any maternal mental health problems before that 3 years and when the survey started at 9 months? So essentially what we're doing is we're back capturing what we would see in the survey as a snapshot, but capturing it backwards in administered data. So for example, the mother could then be asked hypothetically in a survey, since we last met you, have you gone to the GP for any treatment? That would be a cohort style way of asking this question, but instead we filled that in with administered data, and that gets around some issues around self-reporting. There are also loads of issues of administered data, which we're probably all aware of, and I don't have time to kind of go through that. But yeah, those are kind of some of the things that I wanted to kind of bring up, because actually thinking about how we captured this data over time was actually quite tricky, and many mistakes were made, majority by me, and sometimes I'd copy and paste things and then realize I didn't update them. But yeah, that's kind of how we captured the data, and I'll talk about the measures a little bit more as we go through. The strengths and difficulties questionnaire is just a way of capturing children's problems behaviours, and it's a relatively standardised metric used in really social psychology. Just to talk a little bit more about the analysis, I'm not going to do too much detail, just because, again, I don't know how useful sometimes it is, and I think I end up getting lost, to be honest, and deep in a hole, and that's fine when I'm in a hole on a Friday afternoon by myself, but not for a presentation. We use random intercept cross-lag panel models, and we use Bayesian techniques for categorical variables. This was completely new to me, and I owe myself to both Stu and Rhiannon, who really helped me with this stuff, because I had no idea what I was doing in the beginning. I'd never done Bayesian techniques, and this was really challenging and a really good opportunity for me to kind of develop these skills. And this basically means that we look at these bidirectional associations, which we'll see in a figure in a minute. But we also are kind of allowing ourselves to look at how individuals fluctuate around their own kind of stable trait-like level. So basically, how associated are they within person over time? And to establish how good these models were, we used trace plots. So basically, did it look like a big fuzzy caterpillar or not? And we wanted it to look like a caterpillar. And we looked at the proportional scale reduction, PSR, and then we used full information, maximum likelihood for our missing data, making a relatively strong assumption that there's some missing at random. And a lot of papers do this. I think there are potential issues around weighting, but because the model was kind of using this really new methodology, we weren't really able to kind of adjust it any further. It was already pushed to the max, I think. So yeah, a few kind of methodological things there, which I'm happy to talk about at length, kind of if you want to get in touch, but I'm not going to cover too much today. So this is kind of how we have graphically visualize the models, and Stu did a really nice job on Lucidchart. I love these. So this is strengths and difficulties questionnaire. So this is the overall, basically an overall score of children's problem behaviour represented by SDQ, 1, 2, 3, 4 are the time points, and the same for maternal mental health as M health, 1, 2, 3, 4. The pink kind of highlight points are basically the within associations. So how much does maternal mental health at time 1 predict maternal mental health at time 2? We can see an increase in probability of 0.17, but it's not statistically significant. So we can see some association there, and potentially the confidence intervals are kind of closer, but they're not super important compared to kind of maternal mental health 2, 3, 4, and 5, and the same with children's as well. So we can see that maternal mental health predicts basically itself over time, and so do children's problem behaviours. And in terms of that kind of bidirectional relationships, if you look at the green highlights, it's only that strengths and difficulties or children's problems behaviours at age 7 predicted maternal mental health when the child was age 11. So that was the only association we saw within kind of bidirectional associations for overarching children's problem behaviours. We didn't see reciprocal relationships for overarching problem behaviours. We only saw one-way behaviours, which was really interesting, given that a lot of the literature talks about maternal behaviours predicting children's behaviours. And then outside of that, and I'll only explain this once because it's basically the same for every model, maternal qualifications, i.e. The increase the measure, the more qualifications the mother has, had an impact on maternal mental health intersect. So this is kind of all of these together and a latent structure. And as you can imagine, the more qualifications the mother had, the lower the chance was that they would have a mental health condition. This is generally kind of very literature-based. In addition to that, maternal qualifications reduced child problem behaviour and likelihood, again, very common, not particularly anything novel there. Again, similar child sex, so if the child is more likely to be female, they had a lower chance of problem behaviours. And this really matters, I think, for what problem behaviour is, but this is, again, is typical in the literature, and they were kind of related to one another as well. So I won't repeat that because it's exactly the same for most models, but just to give you an idea of how the covariates are working in the model. I would say that this was kind of our model that showed the most reciprocal relations. So this is our emotional problems. So what we did is you get an overall constraints and difficulties questionnaire, and then you can break it down into kind of specific aspects. So emotional problems for anxiety and depression, and conduct disorders or externalizing, so aggressive and anti kind of social behavior, which I'll show on the next slide. But emotional problems showed the most reciprocal relationships. So we can see again the pink lines showing that kind of time point 2 predicting time point 3, for example, within their own mental health problems or emotional problems. What was really interesting is that emotional problems at time point 3, so age 7, in children, predicted mother's maternal mental health when the child was age 11, and then that maternal mental health diagnosis went back and predicted children's further emotional problems at age 14. So you can see there's a reciprocal relationship there where there's a pathway, a transaction of emotional problems in the child being fed back to the mother and that then being fed back to the child. This also coincides with adolescence as well, so lots of things to think about there. And they were, the orange highlight represents where the correlations at the same time point are just covariant, so nothing super exciting there, but it's highlighted because it's kind of important generally thinking about the model. So that was kind of an interesting model, and the same thing for the random intercept aspects I've left up there. For conduct disorder, externalizing symptoms or antisocial or aggressive behaviours, we only found that within associations predicted each other. We didn't find any bi-directional associations for this. And to finish up with the rest kind of aspects. We did also look at hyperactivity. We didn't find any associations for this model in terms of bi-directional associations, just within associations. And we also had a look at peer problems, how children kind of navigate relationships with others, other children. We didn't find any associations there really, only one strong association between child-peer problems kind of at age 7 and then maternal mental health later on, but nothing reciprocal. And this wasn't kind of the key part of the study, but it was something that hasn't been researched that much, so I haven't added too much because I've only got limited time to go through this. But yeah, if you want to look at that, that is in the paper, and we discussed kind of some emerging literature on why we think that these might exist. Okay, so just to kind of think about what all of this means in context, because I think it's all been quite technical, so I will try and summarize and package it up nicely, hopefully. But yeah, we had mixed evidence. So the bi-directional relationships exist specifically kind of for emotional problems. And there are some evidence towards kind of overall child problems, but I think emotional problems are our strongest evidence that there are bi-directional associations or reciprocal relationships going on for emotional problems. And this kind of makes sense really in the fact that it's children's emotional problems being looked at, and it relates then to the mother's emotional problems or kind of diagnoses. So I think there's work to be done there, definitely looking at this more with kind of who reports what, more administrative data if possible, and looking at it over a longer time period, a more equally spaced time period, because we don't do that. And that is one of the assumptions of the model that were kind of neglected. In terms of the between effects, we had strong associations for the kind of random intercept aspects, and we theorized this to be around kind of lower sensitivity. So thinking about mothers who actually struggle with their own mental health, they tend to have kind of a lower positive aspect, struggle with kind of emotionally connecting with their child and being sensitive towards their child, and this can develop and manifest problems. Not something we specifically saw in the model earlier on, but it is worthwhile thinking about in a kind of mechanistic way, I guess. We also think about communication styles as well. So how do the kind of parent and their child communicate with one another, specifically important for emotional problems when we think about how kind of that manifests in parents and kind of that limited patience, that limited capacity, and then that kind of impacts the child, and then, you know, they may kind of internalize those kind of behaviors and reinforce those and perform those as well. Parents are role models after all, and that's really tricky, because there's a kind of a lot of kind of challenging situations, challenging behavior that's going on in that situation. So that's an area that definitely needs support. And there's aspects around family conflict and genetics. And we don't look at genetics in this study, but I think there's definitely work to be done to look at genetics a little bit more, and the contribution of that, particularly when it comes to mental health, some of which is thought to be kind of genetically predisposed. And then we've got our covariates. So higher qualifications have a kind of lower risk for poor outcomes. This is generally known, and boys are at a higher risk for poor development. Again, things that are kind of very established in the literature. So my last slide, in terms of recommendations, we think about kind of family-based interventions, are really useful methods for supporting all members' mental health and development. Obviously, we didn't look at partners and fathers in this study, and that was something that, you know, we really would like to do. And some other papers, for example, Ipsera and Speyer, have done that. So they've done bi-directional associations between mum, dad, and the child. Again, this is all self-reported data, so not it's just beneficial in a different way, because you can look at who differentially reports the aspect or the problem and how that associates one another. But ideally, it would be really good to have some administrative data and to look at this more deeply. But as we all know, partners and fathers do often get left out for all sorts of reasons in cohort studies, and they can be quite hard to link up. So if people are interested in this area, I think it would be really complicated, but definitely worthwhile investing that time in doing that. So I think the findings would be really interesting and really useful to understanding more about family-based interventions and tailoring that. And we also recognise the kind of differing needs dependent on socioeconomic conditions via maternal qualifications and child sex, and the definite kind of spaces for universal interventions to support families with mental health, but also kind of thinking about tailoring, you know, what middle class families experience problems will be very different to kind of working class families, additional pressures in different ways. So tailoring is definitely something that I think would be useful. Okay, so diolch yn fawr, Wrando. Yeah, really nice to just have this opportunity to speak about this research. Again, I haven't picked up for a while, so it's nice to kind of, yeah, present this. And thanks again, special thanks to all of the co-authors. Everyone did a really good job at supporting me with this research, and I definitely wouldn't have been able to do it without all of this support. So yeah, thank you so much.